So our next speaker is David Edwards. Dr. Edwards is a professor in the Department of Kinesiology and Applied Physiology at the University of Delaware in Newark. His research is focused on exercise and cardiovascular function in chronic kidney disease, and he has established a renal rehab program at the University of Delaware. His other area of research focuses on the vascular effects of dietary sodium. He will be speaking with us this morning about exercise for rehabilitation in chronic kidney disease patients. Doctor?
Thank you. It's a pleasure to be here, and I'd like to thank Claudine for the invitation. What I like to do is just talk to you a little bit about kind of what we know about exercise in chronic kidney disease, but really we'll start with kind of the benefits of exercise in general. My background really is in cardiac rehabilitation, and we know a lot about that area, right? It's a Medicare reimbursable diagnosis and so forth. So we'll talk about the benefits of exercise. Most of the things that we know about are related to cardiac rehabilitation. A little bit of data out there in kidney disease, and then we'll talk about some of the things that we've been doing at the University of Delaware. No disclosures. So I thought I'd start with just talking about what are the benefits of exercise or physical activity. And there's a little bit of a difficulty when you go to National Institutes of Health to try to get grant funding for exercise, because their comments from reviewers is always, we know that exercise is good for you, why should we fund another study? So there may be some unique things about kidney disease, but let's just talk about what those benefits are that we know of. So if you go to the American Heart Association, a variety of other organizations, they'll list the benefits of exercise. So improving mood, decreasing feelings of anxiety and depression, helping with weight loss. Nutrition obviously is another important component there. It's good for your muscles and bones. Can maintain muscle mass, maintain bone mass as we get older. Increasing energy levels. If done correctly and not overdoing it, you should have more energy throughout the day. Reducing the risk of chronic diseases. And this is what we think about predominantly when we think about the benefits of exercise, right? From a cardiovascular perspective, improves blood pressure. That'll also have benefits for kidney disease as well. Improve cholesterol levels, reduces the risk of heart disease and stroke. We've heard a little bit about cognitive function today, improving brain health and memory, improving sleep, reducing pain, and finally maintaining quality of life and independence. So one of the themes here is patient-centered outcomes, right? So that last bullet point is important. So what I thought I'd do is share with you a different perspective that the National Institute on Aging uses when they think about exercise and its benefits. So these are real-life benefits of exercise that the NIA tries to inform folks about, so they can think about how it's actually going to affect their daily lives, right? So we really think about exercise in 4 different categories: endurance exercise, strength exercise, balance, and flexibility, and all of which will help in different ways. So if you just think about trying to keep up with grandkids, raking yards, doing yard work, endurance activities will help with that. Strength training, lifting anything really is going to help. Groceries, whatever that may be. Balance exercises, walking along a path that may be uneven, and so forth. And flexibility, being able to move, driving a car, those types of things. A little bit more of kind of a real-life perspective on the benefits that potentially exercise could have. So the other question that we get a lot is, well, really, what should I be doing? How much should I be doing? So these are the physical activity guidelines for the American Heart Association. They're not all that different than some other organizations like CDC, American College of Sports Medicine, which our group is involved with. So really, this kind of 30 minutes of moderate intensity activity on 5 or more days per week is the standard answer that most people will give you. 150 minutes of moderate intensity activity. And we'll talk a little bit more about how can we kind of figure out what that is. You could do vigorous activity for a little bit less time, a little bit less days per week, because you're getting a little bit more bang for your buck, essentially. We'd like folks to do some strength training as well. So we'll talk a little bit about strength training a little bit later, but that's not always accessible to everybody. And the American Heart Association, at least, if you're trying to lower blood pressure and cholesterol, then you may need to be able to do a little bit more exercise for some of those things. But you'll see benefits along the way, as I'll show you, from even just a little bit of exercise. So how do you know if it's moderate or vigorous? So the first part of this is you can use heart rate. But in order to be able to use heart rate, you need to know what your resting heart rate is, and you need to know what your maximal heart rate is. Now, we can estimate your maximal heart rate based on how old you are, but that's complicated by drugs and so forth. So that's really not a maybe feasible way to do things. It also requires some math. So really the easy way to do this is what we call rating of perceived exertion. So on the right-hand side here, you have this rating of perceived exertion chart. And it basically goes from 6 to 20, with 6 is what you're doing now, no exertion at all, and 20 is maximal effort. And it's a subjective scale. And really, if you think about moderate exercise, you're in that range of 12 to 14-ish. And vigorous starts about 15. So oftentimes we'll tell folks, if you think you're exercising in that range of 12 to 15, you're probably doing okay. Another simple way to think about this is the talk test. You want to be exercising enough that you feel like you're doing something, but you're still able to have a conversation with somebody next to you. Okay, if you're going harder than that and you can't have a conversation, it's probably a little bit too vigorous. So the good news is this is a plot of mortality risk, death risk, based on how much exercise someone's doing per week. And MET's hours per week is just a way to quantify the intensity times the amount of minutes that you do an exercise. So if we follow the guidelines, that 150 minutes of exercise per week, that would put us at 7.5 MET hours per week. And what you'll notice is that even less than that, you see a benefit. Would be no exercise. You see a benefit. As you increase with more exercise, it goes down a little bit more, but you really kind of see a flattening here. And the good news is for those folks that like to exercise a lot, is that there's not really an increase in risk if you keep going. So this is up to 10 times what's recommended. Right? And there are some folks that run 80 to 100 miles per week when they're younger and so forth. So that's good news. We think about fitness. So we can look at how much exercise you're doing, but then also a measure of fitness. So if you take someone and you put them on a treadmill and you increase the speed in the grade, you can calculate what their maximal workload would be. And you can estimate their oxygen consumption, how much oxygen their body uses on a minute basis. You can measure that with the metabolic cart, and I'll show you a picture of that later. So here we have just 3 different fitness levels. This is 11,000 men that they measured. They measured them at age 45, 55, and 65. The plots all look the same. So this is the age for the 55 plot. You can see that lifetime risk for cardiovascular disease is the worst in the low-fit group, and it's better in the moderate and the high-fit group. Right? So fitness. So it's not just activity, it's fitness. So you can think about these 2 different ways. Both of those confer some benefit. So I really kind of started thinking about exercise in chronic kidney disease in 2003 when this paper came out that kind of talked about kidney disease in and of itself as being a risk factor for cardiovascular disease. So we knew a lot about exercise and its benefits in reducing cardiovascular risk. And now kidney disease appears to be something that's an additional risk factor. What they talked about in this paper is how if you take traditional risk factors, someone with kidney disease has a greater risk over and above what you would predict from those traditional risk factors. So potentially exercise might be beneficial in these folks. So this increased risk is due to what we call traditional risk factors, like physical inactivity being one of them, and non-traditional risk factors. So our traditional risk factors, and the ones that I've listed here are the modifiable ones. The non-modifiable ones are age and male sex. So these are the traditional risk factors that we think about. The American Heart Association calls these the simple 7. These are things that can be managed. So managing your blood pressure, controlling cholesterol, reducing your blood sugar, getting active, eating better, losing weight, stop smoking, right? And then we have these non-traditional risk factors, which really you could read 10 different papers and they might have 10 different non-traditional risk factors that they talk about. So there's not necessarily a specific list, but common ones that show up are inflammation. It's a good thing when we have an injury we need to repair, but chronic low levels of inflammation are a bad thing. That's common in kidney disease. Oxidative stress or damage from free radicals. Insulin resistance. Endothelial function, which is a focus of my lab, and I'll talk just a little bit about that later. Stiffer blood vessels, and then there's many, many others of those. So what we see is if we compare groups of patients with kidney disease to those without kidney disease, the number of patients that have any kind of cardiovascular disease is much higher if you take the kidney disease group compared to the non-kidney disease group. And that goes across all these different conditions, whether that be coronary disease, heart failure, stroke, and so forth. Right? So you've heard this in other talks this morning, this increased cardiovascular risk in kidney disease. So what do we know about physical activity, fitness, and physical function in chronic kidney disease? So you probably have all heard about Fitbits and different activity monitors. We use what's called an actigraph in the lab, and it measures just movement. You wear it on your hip, and we can get lots of different information from that. So vector magnitude is just how much movement is happening. We can get steps, and then we can actually take this vector magnitude and break it down and kind of get an idea of how much moderate to vigorous activity individuals are doing. So this is just a comparison of folks without kidney disease to those with CKD. In our lab, predominantly, we're studying the non-dialysis group, stage 3 through 5. And you can see that however we look at these data, it looks like CKD patients are about half as physically active. And that's consistent with dialysis patients that have been reported in the literature, where they've just reported this vector magnitude, and you can see that compared to the control group, dialysis is about half of what you see there. And that's a fairly consistent finding, that physical activity levels are reduced in those patients. If we look at fitness, so we do a bike test at our lab. We have individuals on a bike. We start them at a low level and then increase the intensity slowly over time, and we can measure the oxygen that they're consuming with a mask here and a metabolic cart. And you can see that we call this VO2 peak, so it's the maximum amount of oxygen you can consume at peak exercise. That's lower in the CKD patients compared to the healthy, and that's a fairly consistent finding throughout the literature. Somewhere between 50 to 80% of healthy controls is what we see. And there's also evidence that as the disease progresses, that VO2 continues to go down. Physical function. So now we're not just the activity and the fitness level, but what are patients able to do? Physical function is reduced in the kidney disease patients compared to healthy controls. So this is grip strength, gait speed, 6-minute walk distance, so how far you can walk in 6 minutes, timed up and go. Get up from a chair and you walk 3 meters. How quickly can you do that? And this bar in the middle is what would be predicted for someone's age and sex. And you can see that the kidney disease patients are not near that normal level for all these different tests. In general, we see that as kidney function decreases, these get worse. Okay, so this is just a summary slide from a study that did this. They quantified kidney function a couple different ways. But in general, you see that the walk times for a walk get worse as kidney disease reduces and so forth. So it appears that physical function is reduced, and as the disease progresses, it gets worse. You've heard a little bit about that today. And now this physical function that we see in kidney disease is associated with reduced probability of survival. So in all 4 of these, we have gait speed, 6-minute walk distance, grip strength, and timed up and go. You can see that those with the worst score on these different tests have worse probability of survival. So this gets at that whole idea of being able to have physical function, and may get at a little bit of the frailty that was talked about previously. VO2 peak, same thing. You see that those that have a higher VO2 peak, and this is not a very high level. This is it's still considered pretty low, but if this is used as a cut point, those with this higher VO2 do better than those with the lower VO2. So we have different types of patients, right? So this is physical activity levels in different groups. So those that are starting dialysis, the non-sedentaries do better than the sedentaries. If we think about the onset of hemodialysis, the more active you are, the lower your risk is. And if we think about post-transplant, whether it's cardiovascular mortality or whether it's total mortality, those that are less active do worse than those that are active. So it really, there's lots of different, you go from non-dialysis to hemodialysis to transplant, all those groups, activity appears to be important. So there's lots of different figures like this out there. This is one that was in one of our papers. But kidney disease associated with cardiovascular risk. We didn't even talk about the muscle wasting that can occur in that disease. There's a sedentary lifestyle and inactivity that occurs, and that all kind of comes together and can lead to mortality. So the question is, what can we do here that may be important? So exercises appear to be very beneficial in this group. And in fact, in the clinical guidelines, and I'll just read this to you, that cardiovascular exercise at a moderate intensity for 30 minutes on most, if not all days, that should sound familiar, right? Who are not currently physically active, the patients who are not currently physically active should start at low levels and progress to the recommended level. So these are in the clinical guidelines for kidney disease. So not inconsistent with American Heart and so forth. So high physical activity levels are associated with slower declines in renal function. We don't know a whole lot about exercise and renal function per se, but there's a little bit of data, and some of it shows that the decline in renal function in older adults and those with CKD is a little bit slower if you're physically active. This is some data from the VA that with exercise capacity or fitness, those that are the highest fit are less likely to develop chronic kidney disease compared to those that are less fit. So there is some data out there that shows that potentially physical activity or exercise could be protective to the kidney over time. And that's really the very limited amount of data that we have about chronic exercise and kidney function. We know a whole lot more from the cardiovascular side. So what data is there in exercise training and kidney function in CKD? So these are small studies, short-term studies. So to expect changes in kidney function, probably a 12-week study is probably a little bit unrealistic. There's a couple studies out there. Most have shown no change. One study showed a small improvement in EGFR using a water-based aerobics type class. And then there's a study in overweight male CKD patients that had an improvement in GFR that occurred in concert with reductions in fat and blood pressure. So we really don't know a whole lot about exercise training and kidney function, but there's a little bit out there that suggests that potentially there might be a benefit there. So what are the effects of exercise training on cardiovascular function and cardiovascular risk factors in chronic kidney disease? So this is just a summary slide. There was a nice review done in 2011. There's not been a whole lot done since then just about this. So consistently you see that aerobic or endurance exercise improves strength, VO2 peak, or that measure of fitness, quality of life, and physical function. You can see some improvement in leg strength, which probably translates to some of that improvement in physical function. Resistance exercise improves strength and walking capacity, and there's been one combined study that combined endurance and strength training, and you see improvements in VO2 peak and time to exhaustion and so forth. So not surprising that you see these benefits with activity. From a blood pressure control perspective, there's been a little bit out there. So improved blood pressure control in several studies. If you detrain and you stop training, that blood pressure control is lost. Another study didn't show any effect on blood pressure, but it did show a reduction in the number of antihypertensive medications. So, the exercise may be helping to reduce some of the medications that are required to control blood pressure.